Thank you very much, Emily and Tim, for inviting us to speak today. So yeah, my name is Gwilym Owen. I'm a research associate at the University of Liverpool. And we're going to talk today about continuing inequalities in COVID-19 mortality. To start with a quick caveat, as always get a bit of imposter syndrome, and this is the longitudinal area and data link seminar series. The longitudinal and data link aspect of this are not particularly impressive. So if anyone who's come to the seminar looking for some extreme data linkage, they might be a little bit disappointed. The area part of it, though, we're pretty strong on. So hopefully that's okay and you'll enjoy the talk anyway. So this talk is a collaboration between several people, mainly based in Bristol and me based in Liverpool. And to be honest, most of the work has been done by Gareth, so he's the reason we have got the results to present to you today. It just happens to be my turn to present them to you. So I guess I'm going to start with kind of the main reason why we started thinking about this and doing the work. And I guess we're researchers interested in inequalities and particularly geographical inequalities. And obviously during the COVID-19 pandemic, it became pretty clear that there were quite large geographical inequalities in COVID-19 outcomes. And there was also a lot of freely available data, and at the same time, it was kind of tough to think about anything else that isn't COVID-19. So in some ways, it was just felt quite nice, almost therapeutic, just to explore some of the data. And we knew there was a lot of stuff, people doing great stuff on COVID-19 inequalities. So we thought we'd have a bit of fun, decide, see what we could do, and try and see if we could find anything or explore anything, come up with any ideas that people hadn't done before. So particularly the inspiration for the work came from looking from this map here. So that we're talking, taking you back 18 months to September, October, autumn 2020. It seems a really long time ago now. The pandemic changed very fast, so maybe this isn't relevant anymore. But at the time, a map kind of like this is the best one I can find that was available on the internet, really struck us the huge north-south divide in cases of COVID-19 at this time. I think this is based on the report by Public Health England on 15th of the 9th, 2020. And I think probably the divide got even more. And we can argue exactly where the north and where the south is. I found an old paper by Danny Dorling, which had a north-south divide line on the right, and you can see that that fits pretty well with the map on the left, where the dark purple, in case it's not clear, is higher rates of COVID-19 cases. And we sort of wondered why this might be the case. So why are cases so much higher in the north of England? And I mean, one possible solution, kind of answer / non-answer, that you could probably say about almost most health and social outcomes is, well, it's just deprivation, obviously. And there's good reasons, particularly for COVID, than for anything else, why deprivation might have quite strong effects with COVID cases and through that COVID deaths. And for example, there's a really strong correlation between kind of ability to work from home and deprivation. So I think on this from this graph on the y-axis is people employed in sectors which are you're likely to not be able to work from home from, and then on the x-axis we have deprivation. So this seems to kind of make sense, pretty obvious reason, but the mechanisms are kind of interesting. But we kind of noticed that even after accounting for deprivation, cases of mortality were higher in the north of England than they were in the south of England. So that's to say, affluent places in the north tended to have higher cases than affluent areas in the south, and deprived cases in the south had lower cases than deprived cases in the north. So I mean, it suggested some kind of regional effect at this time. So my for idea was that, not particularly seriously, but having lived in both the north and the south, I feel like more people go to the pub in the north, and particularly older people. There seems to be which I thought might have an effect. And if you actually look, YouGov do some polling on this, and that is actually true, but the effects are quite small. So I think probably that's unlikely, but it's kind of interesting whether there were any like cultural differences. I mean, another related thing, this is one of my favorite papers on COVID, looking at the Eat Out to Help Out scheme and showing that actually had quite a reasonably sized effect on increasing cases at this time in the country. As you can see from the map, though, there's not quite such a clear north-south divide, although I think probably actually there were more participating restaurants per capita, which is what the key is, in the north rather than the south. But probably these things probably might have had some effect, but it's unlikely that they were the main thing. But it did get thinking about what is the scale of geographical scale of COVID-19 inequality. Is it local or is it regional? So I find this kind of thing really interesting, as someone who loves geography. But I often wondered, like, is this something that we should really care about? And I don't really have a good answer to that, but I think at the very least it's interesting, and it might be useful, particularly going away from COVID-19 a bit, with the whole narrative, if kind of public debate around the slogan of leveling up, which broadly appears to mean reducing regional inequalities. But it's not quite clear where the inequalities are, where they're between. Are they between neighborhoods within towns? Are they between towns and cities within regions, or are they between regions? Is it which are the inequalities that we want to close? And of course, the answer is there's inequalities between all of these kind of units. But I think certainly knowing where are the biggest inequalities seems like a useful thing to know before you start about spending money trying to improve things. Should we be focusing on inequalities at large scales, or inequalities within regions, within cities at small scales? In terms of COVID-19, whether this matters, I mean, I think it probably would have been helpful in real time during the large rise in cases that we saw in terms of healthcare provision. I mean, whether there's big regional differences or big local differences certainly has different implications for how likely the health service was to be overwhelmed. Obviously, hopefully we're beyond kind of that stages anymore, but it could be potentially useful for understanding future outbreaks. And the diagram on the right of this slide sort of illustrates what I kind of mean by differences between regional and local inequalities. So the level of inequality, so this is simulated data, but let's say it's COVID cases. The map on the top compared with the map on the bottom, they both have exactly the same levels of inequality between MSOAs. So the smaller areas are MSOAs, and in this case, the bigger areas are the local authority districts. So map A and map B, top map and bottom map, have exactly the same levels of inequality. However, you can see actually that in reality this is quite different. In map A, all of the inequality is within the higher level areas, whereas in map B, basically all the inequality is between the higher level areas, where there's no real inequality within them. So this might be an extreme case, but surely this seems like something that we want to know, and something that would be hidden by a single measure of inequality between small neighborhood areas. So in our analysis, we decided to choose 3 spatial scales. So these were regions, travel to work areas, and middle layer super output areas. So broadly speaking, regions, kind of towns and cities in their sort of sphere of influence, and neighborhoods within those towns and cities. So we chose these for a mix of practical and theoretical reasons. So obviously there are many possible different configurations of types of areas that we could use to do this analysis. To be honest, broadly, we found that it didn't really make much difference to the story that we would tell from the data. So I think when we've talked about this before, people have asked us why we chose these and suggested other things, and there may well be better ones to choose, but I think broadly it doesn't really matter too much. We were going for a sort of hierarchy of neighborhood, then city and town around that, or kind of big area around that, and then a regional area on top. Kind of with the idea that most of their daily interactions takes place within their local neighborhood. Whether the MSOA is a good proxy for neighborhood or not, who knows, but that's what we have. And then beyond that, most people travel maybe to work or to socialize in a kind of wider area, kind of town or a city or an area like that. And we've used travel to work areas rather than local authorities, which the government use for most of their data. Because I think the idea is that I think it's 75% of people who work in those areas live in the area, and 75% of people who live in the area work in the area. So for something like an infectious disease like COVID-19, where contact with other people is important, if it's kind of an idea, it's an area where the sort of majority of daily mixing will be happening. And obviously we choose regions because there seems to be big regional differences. And they're quite crude areas. Maybe actually it's really just a north-south thing, but either way, a kind of bigger scale that we're interested in. So our outcome, we use COVID-19 mortality as determined by number of deaths due to COVID-19. So Gareth did a really nice talk to a different seminar series where he talked about a lot about collider bias and all the different biases of different potential COVID outcomes, such as cases and kind of self-reported outcomes, which I won't touch on, partly because I don't know as much about it and I don't think we have as much time. But we decided that COVID, particularly because our research was looking at the beginning of the pandemic, where testing was not widespread, we felt that this was a pretty good outcome. And the data is there available at the MSOA level, or it was available for the first year of the pandemic. So we have from March or April 2020 to about April, May 2021, after which I think the ONS have stopped releasing data at the lowest level. So it's when we're thinking about inequality in COVID-19 mortality, kind of have to remember it includes sort of two quite different processes. So the first is inequality in catching COVID-19. And the second is inequality in dying of COVID-19 after being infected. So the first is obviously related to how many cases there are in the area, how much contact is going on in the area, and it's something that actually probably changes quite a lot over the course of did change quite a lot over the course of the pandemic. The second one is potentially a bit more static, at least at the beginning of the pandemic, I'm guessing more related to how healthy the population are, comorbidities, although potentially there's could be changing geographic inequality due to like healthcare provision availability, whether like the hospitals nearby are overwhelmed or ambulance service or not could change over time. And particularly actually with vaccines, and unfortunately our data doesn't go too deep into the time of vaccines, but it's quite possible that if there's differential vaccination, which I think there is across the country, then this might change as well. But these two are not really possible to pick apart in this analysis, but I think it's important to be aware of them. So kind of taking a step back, kind of more talked about the research question too here, but our broad research questions, I have to say, actually, we've done two analyses of this. So the first one we did for the first 4 or 5 months of the pandemic, and which was published in the Journal of Epidemiology and Community Health. And now we've really done an updated one lately. And so actually, if in that paper, which I think has been released as a preprint, you will see slightly different research questions because they're relating to the previous the previous paper, but in this I'm kind of talking about it all as one, which is really talking about the second kind of updated paper that we did. So our broad questions for the whole study were: how do geographical inequalities in COVID-19 mortality change throughout the course of the pandemic as cases rise and fall? Then what is the geographical scale of COVID-19 inequality? Is it local or is it regional, as I was kind of suggesting before? And then to take this a little bit further, to what extent can these inequalities be explained by area level deprivation? And again, is it local or regional deprivation matters? Is it being, if you're in a deprived region, if you're in like a rich area in the north of England, does that make you more susceptible? So moving on, yeah. So now to the modeling part of it, which is possibly the least interesting part, but I think kind of important to work out how we did it. I think it's really important to go through. So basically, the first thing we do is we calculate the expected deaths in each MSOA for each month, if all deaths were distributed evenly across the country. And the idea from doing that is, if deaths are evenly distributed across the country, there is no inequality. If the rate of death is the same everywhere, there is no inequality. So if there are differences, then that is what we're calling inequality. It's the variation around this. So in terms of the modeling procedure, we use a Poisson model, and we include this expected deaths as an offset. So kind of the reason why we include a Poisson model is because we're dealing with count data, and we're dealing with small counts. So there's going to be variation in these counts across areas, even if there's no actually systematic differences. So essentially what we do is we assume that the counts follow a Poisson distribution, and then we consider extra variation on top of this Poisson variation, or kind of over dispersion, to be our measure of inequality. So the higher the variance around our expected rate after having it taken into account for the Poisson variation, the higher the inequality. So as I said, we're using a multi-level model because we are interested in 3 scales. So as I said before, these are the MSOA, the travel to work area, and the region. So the beauty of the multi-level model is it partitions variance into these 3 levels to give measures of inequality. So I said the variance is our measure of inequality, the kind of the difference around the mean. And the crucial thing is it gives this after it taking into account of inequality at other levels. So to look back at the example I gave of my areas in South Yorkshire, the top one in the bottom right of your screen there, the top one would the multi-level model would tell us that all of the variation is at the MSOA level. All the variation is within the wider area. In this case, it's actually a local authority district, but in our modelling case, within the TTWA, within the region. And the second one, the bottom one, all of the variation pretty much is between local authorities. So the beauty of the multi-level model was that it will allow us to tell these 2 situations apart and say they're actually very different things are going on here. As our measure, we actually use a transformation of the variance called the median rate ratio, which we think is slightly more interpretable in terms of the units, I suppose. And that is the average median ratio, the average or median ratio between rates of COVID-19 deaths between 2 areas picked at random. So at the MSOA level, that's for 2 MSOAs picked at random in the same travel to work area, and for travel to work areas, that's 2 travel to work areas picked at random within the same region. So if there's no inequality, then that will be 1. The ratio between the 2 MSOAs picked at random will be 1 because they will have the same rate. That is pretty much it. And we also included what we've called a negative control. I think it's not technically, that's possibly not technically correct, but what we do is we do the same thing for non-COVID deaths. So we see whether we see whether these patterns that we observe, they're the same for deaths not due to COVID. So, oh yeah, the last bit is then we add deprivation. So we run a second model, including index of multiple deprivation, to assess what proportion of the variance is explained by deprivation. So how much of the inequality is due to deprivation and how much is to do with other things. And again, we decompose the effect of variation into the 3 levels. So we have the contextual effect of living in a deprived region, the effect of living in a deprived travel to work area for that region, and the effect of living in a deprived MSOA for that travel to work area. So conceptually, I think this can be slightly like hard to understand, but it's the region effect will be like regardless of what the deprivation of the area is within your region. If you live in a deprived region, so if you live in an affluent area in the north compared to an affluent area in the south, do you have higher rates of COVID mortality? And then if you live in a deprived area in the north, do you have higher level in a deprived region? I'm saying the north is more deprived, then do you have higher rates of mortality than a similarly deprived area in the south? So I find it a little bit conceptually a bit difficult to get a head around, but I think it is quite interesting, particularly when we're looking at this scale thing. So the results, how am I doing for time? Okay, good. So kind of obviously what you might expect is inequality is variable across time and spatial scale. So here on the bottom axis, you have time going from April 2020 to April 2021. You have the 3 different spatial scales together. And then on the vertical axis, you have the measure of inequality. As I said, 1 is no inequality, higher, the more inequality. And then we have the COVID deaths at the top and then the non-COVID deaths below. So as you can see, the inequality, there is inequality, as you might expect, and it's variable across time and spatial scale, peaking in the summer for the MSOA and TWA level, and for slightly later for the region. So the first, and to be honest, even if nothing else comes out of this, I think this is just quite a like useful and finding, maybe self-evident finding, but not one that I've actually seen discussed by many other people, which isn't to say it hasn't been, but the geographical inequality in COVID-19 mortality is far higher than for non-COVID mortality. So you can see that the median rate ratio stays above 1.5 pretty much at all 3 levels, and for non-COVID mortality it's below 1.5 for the whole time. So where you live seems to matter a lot more for your chances of dying at any given time for COVID-19 mortality. And yeah, I think that in itself is quite an interesting finding. However, deprivation does, well, I know I've got it right. Deprivation does not explain the majority of the geographical inequality. Particularly at the MSOA level and the TTWA level, you can see these peaks have not really gone down anymore much. So on the left, we have without including deprivation in the model, and on the right, we have after accounting for deprivation. So that's quite an interesting finding. We'll kind of come back to why that is later. Nevertheless, the fourth finding, inequality between the most and the least deprived areas is greater for COVID-19 than for mortality from other causes. So even though most of this inequality that we've measured is something else going on, we can still say that that's kind of socially structured. It's like the inequalities are greater if you measure inequality as comparing between a deprived area and a non-deprived area, rather than just sort of comparing the variance across areas as a whole. And I think this is also quite an important finding. Obviously, that's slightly variable over time, but in general, the relative risk ratio is greater, particularly for actually at all three spatial scales, but particularly at region and MSOA level. And then, yeah, we just I'm not sure I put this in this order. To look at the then if we look at Oh yeah, I guess the big thing that the other thing you take away from that graph is that um, the region level, it seems to be very important, particularly in October. So that comes to my next finding. At the peak of inequality in October 2021, the average deprivation of the region mattered much more than the deprivation of the MSOA. So that is only for this period of time from sort of June till January, but the average deprivation of the region is it mattered a lot at this time, and it mattered much more than whether you were deprived within your region. And this is sort of linking back to what we kind of observationally saw earlier, when we were looking at the fact that affluent places in the north had much higher rates of cases, and in this case mortality as well, than affluent areas in the south. And it turns out that I kind of brushed past this a little bit earlier, going back to these MRR graphs without including deprivation in the model and after accounting for deprivation. We can see that this big regional peak is explained by deprivation. These other initial peaks are not at all explained by deprivation, but this big regional peak is explained by deprivation. So the reason why we had these huge inequalities at that time appears to be related to deprivation. I mean, again, making causal claims perhaps is going a bit far, but it seems like it makes sense. Adding in an extra slide here, so you can see on all the graphs we've sort of shaded in purple the time when there were tiered restrictions. So that was obviously there were geographically structured restrictions for a few months. We had two periods of tiered restrictions, actually, with a national lockdown in the middle. And our data is consistent with them being concurrent with a reduction in regional inequality. And going back to this graph here, I put it in the wrong place. You can see that at the peak in regional inequality, as you might expect, the northeast, which is the top one, the northwest, and Yorkshire and the Humber have the high levels of cases, and London, the southeast, and the southwest have low levels of cases. And this inequality closes over that time of tiered restrictions. So our data is consistent with the tiered restrictions perhaps working, although we can't really say. However, it also happens that I've done some other work which led by one of my colleagues, Nina Zhang, looking at the effect of tiered restrictions, and we did a synthetic control design where we used the fact that because the tiers were introduced at local authority level, we actually had places within local authorities that were very similar inside different tiers, and we were able to show from that both in the October and the December tier restrictions, we could see that in the tier 3 areas there were lower cases than there were in the synthetic control area, where what would have been expected if tier 2 restrictions were applied. And you can see from this in October, this meant that it was a reduction in cases, whereas in December this meant that it was an increase. It was an increase in cases, even though the tier 3 areas, so the areas with high restrictions, which were more likely to be in the north because that's where the cases were higher, did better, but they still did badly, and that is because of the emergence of the alpha variant in the south of England. And in some respects, probably a lot of this closing of inequality is actually that we see here is actually probably due to that, because you have a much more infectious new variant spreading in the areas of the country where there were fewer cases, and as a result fewer deaths. So hopefully that's not too confusing, but the final quite clear conclusion we had is that when COVID-19 deaths are low, geographical inequality in COVID-19 deaths are high. And this is a really clear relationship that in we had huge amounts of inequality when there weren't many cases. So it's quite an interesting thing to think of. Obviously, we'd prefer to have fewer cases everywhere, but it does seem to be the case that someone's knocking on my door. I'm going to ignore them. I don't know who they are. It does seem to be the case that COVID-19, yeah, there is that even when it's great because we've reduced cases, there's going to be something to worry about, that actually we still need to be worrying about inequalities, and particularly if these are structured by kind of socioeconomic deprivation, that we don't let these inequalities continue. So our results, to recap, inequality is variable across time and spatial scale. Geographical inequality in COVID-19 mortality is far higher than for non-COVID-19 mortality. However, deprivation does not explain the majority of geographic inequality. Nevertheless, inequality between the most and least deprived areas is greater for COVID-19 than for mortality from other causes. At the peak of inequality in October 2021, the average deprivation of the region mattered more than the deprivation of the MSOA. When COVID-19 deaths are low, geographical inequality in COVID-19 deaths are high. So why is this the case? And we kind of came up with, talking to a bunch of people, with a kind of theory of that sort of brings together all of these kind of results in one. And this is the idea of transmission heterogeneity structured by deprivation. So it's a little bit complicated, but COVID-19 transmission is characterized by large transmission heterogeneity, which is more colloquially known as super spreading. So the idea that the majority of cases transmit to a few or no other people, while there are a small number of cases transmit to a large number of people. So when numbers are low, you see that this process happens. At small geographies. So probably actually the reason why deprivation isn't explaining most of the inequality is it's probably due to this kind of stochastic process, where there might be a super spreading event in one or a couple of super spreading events in one MSOA, and you're suddenly starting to see you suddenly at that time get lots of cases, and then when numbers are low, it might only be a few deaths, but it's a lot more deaths that are happening anywhere else. So probably actually potentially our model, maybe you could argue, is slightly misspecified, as you could argue that this isn't systematic inequality in the way that we normally think about it, but it is still large differences between places at different times. So when numbers are low, you see these processes happen at small geographies. Most geographical inequality is probably due to this process, and the population average effect of deprivation is possibly small relative to the inherent heterogeneity within COVID-19 transmission. However, these events of super spreading events are much more likely to happen in deprived areas, particularly in summer 2020. Interestingly, we haven't done the analysis of September 2021, but it seems like probably this process probably doesn't quite repeat itself. And I wonder if that's because all of the restrictions were eased, and therefore, as going back to what we were saying before, with people living in deprived areas much more likely to not be able to work from home, whether more people were just not working from home everywhere. So actually it didn't play such a bigger role. But our kind of theory is that these events are much more likely to happen in deprived areas, and over time, when cases are low for quite a long time, at a much more aggregated scale, you start to see the signal of deprivation coming through, and that's the reason why we're seeing the big regional differences. So if you're in a deprived region and these events are happening in more places around, it gradually aggregates up to a regional level effect rather than necessarily a MSOA level effect. So I don't know if that's true, but that's kind of the theory that we came up with. And I think it's certainly true that most of the inequality that we observe is due to this transmission heterogeneity. But I still, whether it remains relevant now is interesting, but I still think it's an interesting phenomenon. So yeah, like my original prediction So I hate all social media, but whenever we publish a paper, I feel like I ought to post something about it. So I said a key result from the original paper that we did is that spatial inequalities tend to be higher when COVID-19 rates are lower. That's definitely true. So there's a possible future situation where COVID-19 is seen as less of a big deal, but still persistent in deprived areas, contributing to mortality inequalities in the long term. But that's actually completely wrong. So it's a good thing no one listens to me, and no one really cares what I say, because Sajid Javid, the health secretary, had a great idea of releasing all restrictions. It might actually not have been a terrible idea, considering that everyone was vaccinated, but his idea of releasing restrictions probably actually tackled inequality in COVID cases, because cases just stayed absolutely high everywhere. And I use cases here rather than deaths, because actually with the vaccines, probably the deaths did decline. But the new, so I don't know how relevant most of this is now to what's happening in a vaccinated world. However, the fear is, I guess, isn't that we will only find COVID cases in a few deprived places, but it still might be that we only find COVID deaths in a few deprived places. And I guess the fear with that is because of vaccination. And I took this graph from Colin Angus, who posts loads of good COVID graphs on Twitter, and just I couldn't find many others online, but from people I know who work on this, this definitely does seem to be a big thing where there's a bit of patterning by deprivation in levels of vaccination. So this is for child vaccination rates, but I believe it's the same for adults. And I guess the fear is actually, well, COVID will still continue being everywhere, because that seems to be what's happening. But actually, we'll still be fearful of inequalities in deaths, because in most areas it's less likely to kill people than it is in areas where people haven't been vaccinated. So that, so it's a slightly different process, but I think it is definitely the concern with the inequalities moving forward. The last kind of point because I was trying to think through, like, how is this relevant? How is this interesting carrying on? And it kind of struck me from this that infectious diseases are often more obviously place-based than non-communicable diseases. So it reminded me from one of the first geography lectures that I went to and doing my undergrad, and being fascinated by the work of Peter Haggett, like 50 years ago now, almost 50 years ago, looking at models of epidemic diffusion. And I was like, this is amazing. You can do, like, I didn't realize this was part of geography, and geography can play a key role. But you don't really see this very much. And I don't know whether COVID-19, these are kind of the thoughts I had. I don't know whether COVID-19 is different from other diseases, but there's not too much, you don't see too much work from looking at the social geography of infectious diseases. For example, I looked through the latest articles in Health and Place, the latest 25 articles, and I can only find one, or maybe there was one that maybe included them a little bit, looking at the geography of infectious diseases, which is this really great one by my colleague Susie Rotherham, looking at gastrointestinal infections and some really good qualitative analysis. So I kind of wondered whether there's more to offer, because the things are much more obviously geographical, and you get patterns and networks, and as we found in this, the kind of aggregation effects, which means it's not just often I found looking at other things, you just make a map of this health outcome, and it's basically a map of deprivation in the UK. And I mean, obviously the mechanisms of how the deprivation gets to the health outcome are really interesting, but it often doesn't feel so geographical. Anyway, that's sort of kind of an aside at the end, but I hope people found it somewhat interesting and somewhat comprehensible. But yeah, I happily take any questions.